Hello, thank you for joining us online today. My name is Lisa Fritz. I'm the Associate Director of Clinical Services at the Children's Home of York and a graduate of the Millersville University Social Work Program. Today I will be presenting on the topic of transgender individuals in the mental health setting. Our objectives for today's training are to introduce the concepts associated with treating transgender individuals in the mental health setting, to explore clinical theory, best practice standards, and current law associated with treatment of transgender individuals in the mental health setting, to explore NASW Code of Ethics, APA Code, and other related codes, and our responsibility to transgender individuals in the mental health setting, to identify practical challenges to ensuring affirmative treatment of transgender individuals, and to provide methods to overcome the challenges. To start, I'd like to do a review of some definitions. Some of these may be familiar to some of you, others may not, and I could do a very long list of definitions. I chose those that will be most relevant to our experience today. First, a review of the term sex. Sex, we must remember, is a medical term designating a certain combination of gonads, chromosomes, external gender organs, and secondary sex characteristics and hormonal balances. We usually divide into male and female for the sex identifiers, so this category does not recognize the existence of intersex bodies. Next definition, sex identity. Sex identity is how a person identifies physically, female, male, in between, beyond, or neither. So our sexual identity is non-binary. Gender identification is a person's sense of being masculine, feminine, or another gender. Some examples of this would be transgender, transsexual, genderqueer, crossdresser, etc. Transgender, gender expansive, is a person who identifies as a gender that differs from the sex assigned at birth. Sexual orientation varies. This is not affiliated with gender. Studies indicate that gender is determined by variations in gray matter in the brain. And that is something, I gave some references on the slide that you can look into further. Cisgender describes someone who feels comfortable with the gender identity and gender expression expectations assigned to them based on their sex assigned at birth. And finally, sexual orientation. The desire for intimate, emotional, and sexual relationships with people of the same gender and sex, another gender and sex, or multiple genders and sexes. And again, sexual orientation and gender orientation are not interrelated. They function exclusively from one another. What I would like to focus on primarily today is the common transgender experience in the mental health system. Fortunately, what most individuals encounter are microaggressions, prejudice, abuse, unprofessional behavior, cultural incompetence, and a lack of education. Some examples of these would include not acknowledging a person's identified name or identified pronouns, ignoring a person's gender identity. Abuse can actually be seen in forms of physical abuse or sexual abuse at the hand of a mental health provider. Cultural incompetence is a just general lack of understanding of the transgender identity and experience. And then in a lack of education, it's been found that the majority of colleges, universities do not offer courses or trainings on the topic of transgender, and we also find that within our agencies there are often not trainings offered. Consequences for the transgender population of these microaggressions and prejudices include an avoidance of the mental health system, increased rates of mental illness and self-harm and suicidality, untreated mental illness, increased stigma, and inability to accept themselves, which may result in them repressing their gender identity, and abuse in the family, school, etc. that goes unidentified because they are not seeking help in the mental health system and therefore not disclosing the abuse. Our professional responsibilities as mental health providers to our clients is to identify our own values which may impede us. We need to practice our self-awareness, know where we fall on this topic, and then be able to either adjust and educate our views, be able to separate ourselves in the workplace, separate our own values and views from those professionally, but in whatever way to be able to be self-aware. We need to be able to educate ourselves and our coworkers. We need to identify the microaggressions in our own professional environment, which means looking at all aspects of our environment, physical space, mental space, and I'll be reviewing that later. We need to eliminate microaggression from our interaction with our clients. We need to be knowledgeable of our federal and state laws and how they impact the services that we provide. And we need to be knowledgeable of our professional codes. I'm going to begin by reviewing some law. In August 2018, the Pennsylvania Human Relations Commission, which is the government agency that enforces the Commonwealth's non-discrimination laws, began accepting complaints of discrimination against LGBTQ people in employment, housing, and public accommodations as a form of sex discrimination. Title VII of the Civil Rights Act has determined that gender discrimination is equivalent to sexual discrimination. So when we look at our equal rights laws and amendments, we need to understand that when it lists sexual discrimination, that gender discrimination now is in the same category. Further law, Title IX, Educational Amendment, prohibits federal money from being given to schools that discriminate based on gender discrimination. So this carries over into all aspects of our functioning, our agencies, our lives. The Equal Protection Clause of the 14th Amendment guarantees equal protection under the law for transgender individuals. And what is being seen in Pennsylvania is that if these cases go to court, the individual is winning. So we need to be aware and be certain that we're providing equal services and non-discriminatory services. Examples that can be seen of this are the bathroom lawsuits that have taken place. The rights of the transgender individuals are being upheld. Next, I'm going to do a review of the DSM-5 diagnoses of gender dysphoria. As of our most recent release with the DSM-5, we had the success of having transgender removed as a mental illness diagnosis, which was just wonderful for us. Being diagnosed with gender dysphoria, which is the current qualifier in the DSM-5, does not indicate a mental illness. Gender dysphoria diagnosis merely describes the dysphoria, the uncomfortable feeling, when the body and gender identity do not match. What this diagnosis does allow is for assistance in obtaining hormone therapy and gender affirmative surgery. A review of some statistics, just to reinforce again what transgender individuals are facing and what opportunities we have to either help or hinder them. In the 2015 U.S. Trans Survey, 39% of respondents reported experiencing serious psychological distress at some point in their lifetime. 40% attempt suicide in the course of their lifetime. 47% are sexually assaulted in their lifetime due to being transgender. So this is after they come out as transgender. 77% experience harassment in school between grades K through 12, and 30% of trans are homeless at some point in their lives. The good news is that the trend is changing. More recently, there have been reports that have found that 60% of transgender individuals report support from their families after coming out. 68% of openly transgender individuals report support from a coworker, and 56% of transgender individuals report support from classmates. In 2016, the University of Washington did a study of children ages 3 to 12 years old who were supported by their families in their transgender identification. Interestingly, what they found was that levels of depression were equal to their cisgender peers, and levels of anxiety were only slightly higher than their cisgender peers with this population. The study will continue to follow the children as they grow, and we'll study other social influences, but the indication is that in a culture of support, transgender children can experience normal levels of mental illness. So what all of this ties up to mean is that we must create a culture of affirmation for our clients. And we have codes and guidelines to help us do that. Some examples would be the Residential Treatment Facilities Beacon Health Options Performance Standards, guidelines for psychological practice with transgender and gender nonconforming people. And I just have a little footnote there that gender nonconforming is now referred to as gender expansive. This guideline was put out by the American Psychiatric Association. And then we have our NASW Code of Ethics. The overall guidelines that you find that are similar in all of these codes would be that professionals have a knowledge of the differences between gender and sex and how the two interact, which is why I referred to the definitions in the beginning. That professionals are knowledgeable of the effects of prejudice and societal barriers on transgender individuals. That professionals have knowledge of how mental health and being transgender may or may not be related, which is something I will address later. We as professionals are to practice with cultural competence. Professionals are to have an awareness of their own attitudes and values. Professionals need to work for social change, and we need to educate our fellow professionals. And then, given that this is our social work conference time, I did pull up a few specifics from the NASW Code of Ethics that apply in this particular situation. Primarily, the Code of Discrimination. We should not practice, condone, facilitate, or collaborate with any form of discrimination in our practice with our clients. Cultural competence. We should have a knowledge base of our clients' cultures and be able to demonstrate a competence in the provision of services that are sensitive to clients' cultures and to differences among people and cultural groups. And we should have practice competence. We should provide services and represent ourselves as competent only within the boundaries of our education, training, license, certification, consultation received, supervised experience, and other relevant professional experience. And now, some examples of what an affirming environment looks like, how we can create an environment that is welcoming and accepting for transgender individuals. First, We need to eliminate microaggressions and prejudice from our agencies, whether they be outpatient, partial, residential, inpatient. You can find it anywhere. Some main examples of this would be if an agency that does not use the identified name or gender identifiers. We need to know from intake what a person's preferred name is, what their preferred identifiers are. We need to be asking, we need to be respecting. We should never question a person's transgender identification. We should not be asking personal and probing questions that are unrelated to the reason for treatment. And a big example of that is asking a client questions about their transition. If they have not come to us for treatment related to transgender issues, related to transitioning, we should not be asking. That is personal information and really just none of our business. Some professionals struggle with wanting to treat transgender issues rather than presenting issues. We must always keep it in the forefront of our mind that just because a person identifies as transgender does not mean that all anxiety, depression, whatever their diagnosis may be, is related to the fact that they are transgender. They may simply be individuals who have depression, anxiety. We treat for the reason they come to us. Some examples for facilities, especially residential and inpatient, but really even in our outpatient offices, something that we should be aware of. Do we have gendered bathrooms? In a residential facility, are there gender specific areas in the milieu, in the bedrooms? And if we are within an agency that provides group therapy, do we have gender specific treatment groups? These are all forms of microaggression and prejudice that can happen whether overtly or even on a subconscious level. Some examples that have been presented in studies is that there can be the open prejudice where a professional will address a transgender individual as a client and tell them that they disagree with their transgender identification. They will openly mock them. Like I said, there are instances of open abuse. However, we also need to remember that clients sometimes overhear us speaking. That is a microaggression. We need to always be aware of what we are doing, mindful of who is in earshot, eyesight, and be cognizant of how our behaviors, our words may be affecting others. We need to provide culturally competent treatment. Part of culturally competent treatment is first to remember the mission of your agency and then provide treatment related to your specialty. For an example, the Children's Home of York, we provide mental health treatment, we provide trauma treatment. We do not provide transgender treatment as a specialty. We do not provide drug and alcohol treatment as a specialty. When a transgender individual comes into our program, we treat their trauma or the presenting mental health issue that brought them to us. We do not do transgender therapy. We are not all transgender specialists within our mental health setting. We need to practice within our field of competence. Be transparent in our professional competency and our treatment goals. If you are in an agency where you are working towards becoming more knowledgeable of transgender issues, this is a field you would like to pursue, be clear with the client at what point you are at. If a client comes in who is transgender and is being seen for other mental health issues unrelated to their transgender identity, but it's still not a topic that you feel well educated on, be upfront with the individual about that. So if you make mistakes, if you have questions, they will understand. and be accepting, and you'll be able to work more comfortably with them. But don't go to the client with your questions, please. Their job is not to educate you. Find your education in workshops, training, consultation with fellow clinicians, not your client. Be culturally competent in individual and family sessions, treatment team meetings, all aspects of your professional day. We need to create an environment that is culturally competent, not just aspects of the agency. It needs to be the entire agency. And also be clear in your procedural and treatment expectations with families. Know your agency policy. Again, an example from Children's Home of York, we follow a very strict policy. Any clients that come into our agency identifying as transgender, we acknowledge and honor their gender identification, their chosen name, their chosen pronouns. Not all parents are always in agreement with this. We make the parents aware of our policy. We work with parents and clients to find a middle ground and how we can all sit down, function together, do sessions together, but we are always clear on the expectations, clear on where we stand from the very beginning, so that it is not an impediment to treatment. If it is an impediment to treatment, we know that right away, and we can work through it and proceed on to what the goals are that we need to accomplish for the client to avoid distraction with the transgender identity conflict that may be occurring in the family or at the time. We need to develop culturally competent staff. We need to have staff educating themselves and receiving training from the agency. Staff need to be open to change in policy and procedures. This will constantly be happening as an agency has a growing transgender population. You'll see changes in how we complete paperwork, how that paperwork looks. You'll see changes in how possibly clients interact with one another. Staff need to be able to work through these changes. Maybe not always completely easily, but they need to be open to it. They need to ask questions. They need to be able to work together as a team. Staff need to be welcoming of the transgender client population, and staff need to be committed to protecting transgender clients from bullying by peers, and really also to protect the clients from bullying by other staff that may occur. To create an affirming environment just for when people walk in the door and look around, some of the things that you can do are look at your policy, look at your signage. Do you have posters acknowledging that you are LGBTQ friendly? Do you begin by being affirming at intake? As I said, asking at intake, what is a person's gender identity, name, pronouns? Put all of that forward on that initial paperwork. It gives an air of comfort and acceptance. Some agencies use name tags so that we're sure that we're using the appropriate name. Be clear with your paperwork and know the law. And we found at Choi that as we moved forward in this area and our transgender population increased, insurance companies, licensing bodies were more than willing to work with us through that time of figuring out paperwork and how to make sure we were completing it accurately so that we met the needs of the client and the needs of the law. Be aware of bedroom assignments if you are an inpatient or residential setting, bathroom and bathing assignments. Make regulations that are appropriate, that are affirming, and then make them known to the clients. And whenever someone's coming into a group residential setting, always up front, speak with them, let them know what accommodations you can make for them, what your environment will feel like for them. It helps for them to know that in advance. Maintain confidentiality. If a transgender individual comes into your program, we will know as professionals the birth name most likely. Do not share that. That is confidential information under HIPAA. Any changes to gender identification, again, confidential information, protected information. In situations like residential situations, again, group homes, inpatient settings, we do have the disadvantage of state law working against us. Facilities are licensed as male, female, or male and female. So if you have a female licensed facility and transgender males in the building, the residents know that this person was born with a female sex identifier. We do not need to give them the information though. They'll figure it out on their own. We don't need to give it. If a client reveals their birth name, we can reinforce that name is not to be used. We can stop bullying if it becomes active. We can stop inappropriate questions. We can have some influence on the confidentiality in the building. If you're in an outpatient setting, you should be taking every measure possible to make sure that no one in that agency knows birth name, birth sex, unless they absolutely need to. And the results of an affirming culture. What has been seen in research is that clients, transgender individuals who are able to find services with open and affirming mental health professionals and find support from friends, family, which we as professionals can always work to enhance, exhibit a decrease in mental health distress, a decrease in suicidality and self-harm, an increase in self-esteem, an increase in acceptance of themselves, and an increase in use of the mental health system. And just like with any other population, keep in mind one bad experience with one mental health professional can keep a person from going back a second time to any mental health professional. This is a very urgent issue that we need to be aware of and educate ourselves on. Unfortunately, we cannot do questions and comments today, but I do have my contact information on the PowerPoint that you've been able to view. If you have any questions or if you would like a copy of the PowerPoint, which the PowerPoint also includes the reference list for my resource information for my slide, you can either email me at the email address or you can call me at the phone number on the PowerPoint slide. Thank you.